But so for those of you that have not heard from me yet, my name is Emma. I am a fourth year medical student, nearing graduation now. It's kind of a subtle countdown in May. So I will be applying to internal medicine. So, or I am applying to internal medicine for internal medicine residency. You know, aside from that, what we're talking about today, as we kind of have been leading up to it, is cases in medical ethics. So we haven't really had the opportunity to talk too much about ethics. So this is a rather, you know, non-traditional presentation for virtual rounds. But I figured a good one for you guys to kind of discuss, especially going into you know, your interviews and MMIs and things like that. So we're going to talk about 3 cases today in medical ethics, and it's really going to be more of a discussion. So if you guys are comfortable with it, I would love for you to unmute yourself and discuss it and discuss kind of different concepts and things. I think it's just easier than typing everything out, especially if you're not a fast typer. So unmuting yourself, I think, is perfectly okay and an easier option in a lot of regards to kind of discuss things. That's going to be, you know, kind of a good portion of the talk today, is that we're going to kind of go through different ethical principles, and hopefully you'll have a good standing or a good understanding of these things, you know, walking away from this. So without further ado, let me give you the pre-poll here, and no fear, I actually changed it this time. So go ahead and answer that poll in terms of your knowledge about medical ethics. And I hope you guys know the show that this GIF is from. I'll be sad if you don't. I think most of you guys are in there. All right, we'll end it there. A few of you didn't answer, but it looks like, you know, it's kind of split almost 50-50 between I know a little and I know some. Some of you said you know nothing. That's okay. Ethics is in medicine is pretty far-reaching. So we'll talk about a few of those principles and a few of the main ones that, you know, you should definitely take away from this. There is a quiz associated with it, and kind of a soap note alternative. I'm going to give you that or kind of talk about that that soap note alternative here in a couple seconds. But here's that link for the soap note, the slides, all that stuff that you'll need for tonight's presentation to kind of follow along. Okay, so as I kind of talked about, we're going to be going through cases in ethics. We're going to talk about 3. We're going to kind of have a discussion about them and various ethical principles. As I kind of alluded to before, you know, don't feel free, or actually do feel free, don't feel afraid to participate and kind of voice your opinion and your thoughts. You know, it's not going to be like this heated debate by any means and kind of ruffle anybody's feathers. But there is, you know, a few things to be said in terms of pointing out ethical principles and things along those lines. So we're going to go through a lot of things like that, and it is going to certainly require a discussion. And for the sake of the discussion, it's definitely easier if you guys unmute yourself and kind of voice your opinion in that regard. I would certainly appreciate it. And then my kind of disclaimer is these cases were taken from Santa Clara University. They did a great job kind of discussing the medical ethics and kind of laying out those ethical principles within cases. So I wanted to stick to the same format and do cases so we can kind of go through them and put them into you know, a real life case and not take that element away from rounds. So I found these cases, I think they're excellent, and we're definitely going to discuss each of them individually. So, all right, let's keep it moving. So, as I kind of talked about before, here's the soap note alternative. And now, in the soap note alternative, it's going to be really easy for you guys to do. All I'm asking for this is choose one of the cases. There's 3. And what you're going to do is discuss the major ethical principles that are kind of outlined in that case. At least 500 characters, and no longer than 1,200. So, you know, that's not very long at all. If you think about it, your personal statement for med school is 5,300 characters. So, you know, this is only a fraction of that. So I'm not trying to take up a lot of your time by any means. I know you guys are busy, probably back in school and have, you know, things to do. So that's all I'm asking for that. So, you know, put a little bit of effort into it and kind of really try to capture, grasp those ethical principles. And I think, you know, you'll walk away from that, you know, learning a little bit. The quiz, as I kind of always promise you guys, should be fairly simple. You should be able to watch this, you know, session either recorded or here live with us tonight, and be able to do those quizzes, you know, in a couple of attempts tops. I'm never trying to trick you guys. You know, it's fairly straightforward, and I try to make it as simple as possible for you. All right. So like always, let's mark where we're at tonight, wherever you're at in the world. You guys are getting quick at marking. Oh, there you go, Matthew. All of your Canadian friends are here this time. Last time they were all not here. I don't know where they were. All right, we have looks like Texas, California. Perfect. We have some East Coasters, some Midwest, lots of people from Canada. They're all here this time. All right. Well, wherever you guys are at, thanks for coming. I hope it's not too cold wherever you are. And if it is, I hope you're staying warm. You have your Snuggie or whatever you use. If Snuggies are still cool, I guess. Hope you have that. All right, let's keep going. All right, so here's the first case. I'm gonna ask that I will read the first one. How about that? And then I'm gonna ask for 2 volunteers to read cases 2 and 3. And then just to get you guys kind of introduced into it, we do have some discussion questions that we'll kind of talk about. But at the end of the case, there is a question that's kind of proposed by the case. So we'll kind of go through that, and I would greatly appreciate if you guys, you know, participate, unmute your mics, and kind of chat with me. That'd be excellent. If you guys, you don't have to necessarily turn on your cameras. If you have like, you just took a nap and just woke up and you have bedhead, that's totally fine. Just unmute yourself, and we'll certainly have that discussion here within the next 3 cases. All right, so here's the first case. At 80, RL lives with his wife in a retirement community. He has always valued his independence, but he recently has been having trouble caring for himself. He's having difficulty walking and managing his medications for diabetes, heart disease, and kidney problems. His doctor diagnoses depression after noting RL has lost interest in the things he used to enjoy. Lethargic and sleepless, RL has difficulty maintaining his weight and talks about killing himself with a loaded handgun. He agrees to try medication for the mood disorder. 2 weeks later, before the effect of the medication can be seen, RL is hospitalized for a heart attack. The heart is damaged so severely it can't pump blood to keep the kidneys working. Renal dialysis is necessary to keep RL alive, at least until it's clear whether the heart and kidneys will recover. This involves moving him 3 times a week to the dialysis unit, where needles are inserted into a large artery in a vein to connect him to a machine for 3 to 4 hours. After the second treatment, RL demands that dialysis be stopped and asks to be allowed to die. You are RL's physician. What do you do? Okay, so that's kind of the question that's posed. So, in your guys' opinions, all of you guys that are here with me tonight, what is to do at this point? So this is kind of our case. What do you guys think we need to do? What's kind of the first thing or the thoughts that come to your mind at this point?
Hi, I'm Sonal Sachdeva. There's some ethical principles we can use.
Mhm.
Under autonomy, we should let him, like, he has a choice over his body and he
Mhm.
can request anything. But as physicians, we have moral obligations to, help people
Mhm.
and our community. So it is in our best interest to keep him alive and continue on with the treatment. There's no right or wrong way to take this, but if I was in the place, I would continue the treatment. And I think the moral obligations and utilitarianism is greater than the autonomy in this case.
Okay, certainly. I think you definitely pointed out some good things. Anybody else had any thoughts or kind of similar thoughts along those lines?
Hi,
Just
can
have
you hear
you
me?
care?
Yes.
So just based on the second to last paragraph where it says the dialysis would like be needed until you can see if he recovers, or like maybe try and plead with him to do like one or two more times just to get a better feel for how it's going. And if it's not like looking positive, then we consider his opinion more seriously. Not to say that's not serious at all, but like, just to see how it goes.
Okay. Yeah, definitely. So Adam says, work with a psychiatrist. I think that's can certainly be warranted. I think you're right. At least, while this patient's in the hospital, in terms of, talking about getting on a right medication to manage his depression, because this might be something of which is transient as a result of the depression. The idea of not making permanent decisions based on temporary thoughts. Okay. Talking through into completing his dialysis, perhaps, yes, the benefits and risks associated with it, and kind of what can be seen as a result of that. I think Emily raised her hand. What do you have?
Hi, I completely agree with like what everyone else has been saying, and I noticed that like since he has to sit there for like 3 to 4 hours a couple of times a week, that might just be leading him to like being bored. And so like I think something that we can do is try to see if the facility that he's in is like just not treating him well while he's there, and if there's anything we can do to like help encourage him to keep doing dialysis at least for a few more weeks.
Good. Yeah, I agree with that too. And something I always think about in this when we talk about this is compliance perhaps, and someone talked about the ideas of patient autonomy. When we talk about our approach, we're talking about beneficence, so doing what's right by the patient. And when I, talk about compliance and all these things, I also talk about this idea of, getting the patient support system involved. And that's often something that's so incredibly important in medicine, whether it's, smoking cessation or, substance abuse, alcohol abuse, with this patient, it seems like, we might need to talk to the family too, to see, if this patient has good support, especially because we're talking about, something going on medically with the patient's heart attack and corresponding renal failure, but also because the patient has depression as well and is being treated medically for that. Perhaps is it painful to actually go through dialysis? Yeah, so the patient, there is some pain with that. They usually have a fistula put in, which matures over time, so it's easier access. So an AV fistula. And it's just a burdensome process. So I guess my question now for you guys, and we're gonna have a series of questions that we're gonna talk to, or talk through rather, but when we talk about this patient, when do we say that pushing this patient towards doing dialysis and doing this, which is a fairly cumbersome and they're already sick enough that they're requiring dialysis, when is this going to sort of turn a corner and be futile? Where do we draw that line? I know that that's a hard question, but what do you guys think? Yeah, signs of improvement, sure. Yeah, so we can base it off of that. You know, is the patient improving? Are we doing more harm than good? That's basically where we want to kind of draw the line. Are these interventions helping, or are we just kind of you know, doing unnecessary things that aren't necessarily working in the patient's favor? That's where we're kind of drawing that line. If his depression worsens, certainly. Okay. So my first question is this one here, which is, does the patient's depression impair his decision-making capacity? What do you guys think? Yes or no? And why or why not? So in the meantime, when we talk about competence and capacity, do you guys know the difference between competence and capacity? If we can kind of start there and then kind of transition into whether this depression is impairing his decision-making capacity. You think it does? Because he lost interest in his hobby, sure. Definitely. So because he's coming suicidal, sure, and suicidal thoughts and suicidal ideation can impair someone's decision-making capacity. That is you know, a lot of the reason behind, you know, some of these involuntary holds in terms of psychiatric patients. So in Florida, we call it the Baker Act. And in a lot of places, it's you know, an involuntary behavioral health hold for somebody to be evaluated by a behavioral health professional to say you know, whether they need to be admitted for suicidal ideation or homicidal ideation or and any of those things. So competence, ability, and legal decisions, exactly. So competence is determined by a judge, whereas decision-making capacity is decided by, you know, physicians and providers. So that's kind of the difference. And I would agree with you guys. I think does depression inhibit or, you know, impair someone's decision-making capacity? Yes, it certainly can. Does it always? No. You know, you and I have probably been depressed at one point in our lives, or maybe not. And that may not have impaired our decision-making capacity, but you know, it was there. Maybe we lost interest in you know, your activities or this or that. It may impair your decision-making capacity, maybe not. So that's something that we need to weigh here, because I think a lot of times in medicine, people are like, or, you know, providers and clinicians are apt to say, because someone is not agreeing with that we need a psych consult because you know, they're not making a decision that is kind of congruent or parallels their own, which doesn't always mean that they don't have decision-making capacity. So that's the big kind of thing here with this patient, is determining if this patient RL has lost decision-making capacity secondary to his depression. So that's the big thing here. So my next question for you guys is, how should informed consent be approached in this particular patient? So somebody out there, let me know how you would approach decision-making capacity with, or informed consent and, you know, determining this patient's decision-making capacity.
You'd have to ask, like, specifically if he understands the risks of treatment and not treatment. And I think that goes into the benefits, like you're saying. You know, the benefit of the treatment is he could improve or he could not improve. It's nice to get family members involved there as well, I think, at that point.
Good, I agree. Anybody else? So the question is, how would you approach decision-making basically, how would you approach determining whether this patient has decision-making capacity and going about the informed consent process? So as Josh kind of alluded to, there are a few things that we want to talk about in terms of informed consent. This might be something that you're aware of because of, experience in getting informed consent for research studies. It's, a very similar process. Give him a set of questions. Yeah, certainly we can kind of follow a dialogue in terms of that. But in terms of informed consent, yes, we're talking about the benefits. So if we're talking about dialysis, we're saying, dialysis, the kidneys by kind of definition are filters for the blood. So it takes in the blood, it filters out all the toxin and it excretes it, as a result through the collecting tubule into the urine to be excreted. Now, when you have kidney failure, all those toxins kind of back up, whether it's, ammonia, different electrolytes, you can get hypernatremic, hyperkalemic, which can cause arrhythmias. So it can cause other problems. So the benefits kind of go along with the risks there in terms of risks of not doing it, but also risks of doing it. So we talk about risks of doing it, putting in a fistula, there are infection, the time that it takes to actually be dialyzed. The benefits of doing it is feeling better. A lot of patients of whom have electrolyte disturbances and on dialysis are immensely tired. They don't have kind of the strength to get out of bed. And even, if this patient is sick enough where we're talking about something like palliative care, or we're talking about, hospice, if the patient gets to that point, doing dialysis, necessarily save their lives or anything along those lines, but at least is an option for palliation for this patient to have a better quality of life in their remaining days. Okay. So yes, we're talking about the risks, bleeding, infection, things along those lines. Alternatives. So what's the alternatives for that? Not a lot in this regard. Outcomes, so improving, the quality of life for that patient. That's what we want our outcome to be. And then always giving the opportunity for questions. I think that that's incredibly important, not just being like, here's a crap load of information and then just fail. We want to give opportunities for questions, because I think a lot of times we forget that, patients aren't, trained in these $5 words that we learn in school and throughout our education. So giving them the opportunity to say, when you talked about the blood coming in as a filter, I don't really understand that. I want to, understand their health, because that gives them kind of leverage in decision making too. Okay. My question for you guys now is, are depressed patients able to give informed consent?
I think that they are, because just because they have a mental illness doesn't necessarily mean that they're incompetent and that they're not, or that they're not like understanding what's being told to them.
Sure. Yeah, I agree. Perfect. Yeah, I think you're absolutely right in terms of, if they are depressed, can they say yes or no? Certainly. They haven't lost their ability to make decisions or to give informed consent for things like dialysis or other things that will need informed consent. Okay, good. Anybody else have any thoughts about this case in general, about kind of this depressed patient? The biggest things that we're talking about here are obviously decision-making capacity in patients of whom have psychiatric illnesses or impaired decision-making capacity. But anybody else have any other thoughts or anything that's kind of lingering in your head, or any questions?
Would something like a living will, where they would have like a no heroic measures, DNR type of stuff, would that have kind of preempted this, I guess?
That's an excellent question. And if any of you guys go into primary care, you're probably going to have a lot of these discussions with patients in terms of having a living will, having power of attorney, having an advance directive that precedes things like this. Because as you can imagine, unknowingly things can happen, and it's good for the physician, the family, all of these things to know what you would want done if things like this happen, where the patient is not able to make decisions for themselves. That's an excellent question. And it leads me to what we call kind of, decision-making capacity, or, power of attorney, advance directives. In most states, if you are married, the decision-making capacity therefore goes to your spouse. If your spouse is, say in the car wreck or whatever themselves and not able to make a capacity or doesn't want to make the decisions, it goes to living adult children. And then after that, it goes to parents. So it kind of follows that trend. And then, if there's nobody after that, then, it can go to like friends or close friends or other relatives. But that's usually kind of the progression there. But assumably, hopefully, if this patient doesn't have decision-making capacity or is obtunded for any reason because, they have electrolyte abnormalities, or because they have an encephalopathy because of increased pneumonia, increased ammonia levels in the blood, that hopefully this patient has an advance directive in place that says, if this were to happen, if I'm not able to make decisions for myself, I would want this. For instance, I have an advance directive, and I recommend you guys do this. You go to your state's public health website or your state's health department. They usually have them where you can print out and fill them out. And you're never too young for this. I think it saves people the problem or the stress of making decisions and trying to assume what you would want. So if anything were to happen to me, mine is like pretty specific. If there is no clear beneficial outcome of the intervention, I don't want like heroic measures. You don't have to intubate me and mechanically ventilate me and sedate me. So that is kind of out. I would want just IV fluids, no tube feeds or anything like that, and basically palliation if there's no kind of reconcilable therapy. And that makes it pretty clear for people. They have that kind of laid out. But the other side of the coin is like, when you draw that, that's where the health professionals kind of come in and say, at this point, I don't think that interventions will be beneficial. So, and you guys will kind of see that throughout your education, hard decisions being made in terms of that. And so to answer your question, Josh, I think that hopefully the decision has kind of preempted that. And when patients are admitted to the hospital, in medicine, in internal medicine, we always ask, if your heart were to stop, do you want us to do, chest compressions, and try to resuscitate you? Do you want to be intubated? Do you want a tube down your throat and be hooked up to a machine that helps you breathe? Do you want these kind of interventions to kind of help, save your life if you were to stop breathing, if your heart were to stop? And they make those decisions, no, actually, I don't want to be, I don't want to be intubated. So that's a DNI. I don't want to be resuscitated. So that's a DNR. Yes, hopefully those conversations precede this, but that's an excellent question. Anybody else, any other thoughts or comments or anything? All right. Excellent. So let's keep it moving and head on to the next question. So the next case that is. Sorry, I don't know what's going on. All right, so let's get one person to read this case, if we can.
I can read it.
Great.
Okay. Mr. Chen, a 40-year-old patient originally from China, has had lumbar problems for 1 year. The condition includes dull pain in his right leg and the inability to sit still for long periods. X-ray examination reveals a prolapsed lumbar disc. He has been treated with conventional pain medication with minimal effect. His physician, Dr. Robert Olson, recommends back surgery, but Mr. Chen is reluctant to take this option. Instead, he asks the doctor to refer him to an acupuncturist because his insurance coverage requires physician's approval for alternative therapy. He mentions to the physician that he has tried acupuncture before and it has helped him. But Dr. Olson is skeptical about any kind of alternative therapy. This derives partly from his belief that allopathic medicine, the approach taught in Western medical schools, is the most efficacious because it has been scientifically proven through clinical trials. He has also had extensive positive experience with surgical treatment for Mr. Chen's condition. In his view, other forms of medicine are at best placebos, and he does not see it as his duty to recommend them. He refuses to order the acupuncture. Did the physician act ethically?
All right. Thank you very much for reading that. I know it can be kind of long. What do you guys think? Did this physician act ethically? Why or why not?
I don't think so, because he was bringing in his own beliefs and his own views, and it's not about his views and beliefs, it's about his patients.
Sure. Okay. Anybody else? Any other thoughts?
I think he could have, explained his side, but then still gave the order for acupuncture, because he knows that it did benefit the patient in the past, and he could say that if that doesn't work, you can come back and have the surgery.
Yeah, sure. Giving kind of options and kind of relaying to that. So somebody asked, could this be a conflict of interest? What do you guys think? So for me, yeah, it could certainly be. And in terms of when I think conflict of interest, I would say conflict of interest, yeah. If he is the surgeon, I would say yes. But when we think conflict of interest, maybe it's like he's getting conflict of interest would be which you can't do in medicine, is like, say his spouse or his business partner is a surgeon, or he's part owner of the surgery center down the road and he's referring all of his patients to that surgery center. So he obviously has a conflict of interest in that regard, in terms of being involved and maybe getting a kickback from that. So that might be a conflict of interest in that regard. Monetary interest, certainly. Especially if he gets, a kickback from referrals or anything like that. This patient, if, would want not to do the surgery, this would be something that, and the physician believes in it pretty thoroughly, would need to kind of document thoroughly, in the instance that anything happens to this patient. But what's the ethical principle at hand here? Do you guys know? This patient wanting to do this intervention, but the physician doesn't necessarily agree with that. Do you know what the term is? We talked about it a little bit last time with the last case. So this one is a lot of kind of discussion in patient autonomy. So the patient having, and when we talk about patient autonomy, it's the patient has the decision or the ability to make decisions, whether we agree with them or not. This could certainly be a conflict of interest, but the patient or the physician has decision-making capacity also to decide whether or not to treat somebody. The thing about it, though, is you can't abandon your patient. for instance, not all gynecologists have to perform abortions. So that's thing that's a hot topic in in medicine, and with new laws coming about in terms of that. So and some laws prohibit it after certain periods of time. But say there is a physician of whom their religious beliefs sort of contradict the ability of a woman to get an abortion. So and they don't want to perform abortions. It's kind of against their religious beliefs. They don't necessarily have to. But if a patient comes to that physician and says, I want to get an abortion, they can't say, well, too bad, so sad. You can't have one because I don't want to. They have to, give them an option of someone else of whom can perform that procedure. The patient has the autonomy to make that decision. And because you don't do that doesn't mean you can abandon them. Same thing if the patient is non-compliant with your regimens and not a good patient by your standards. The same way patients can fire physicians, physicians can fire patients from their practice, which I know it's like, you can do that, but you can't abandon them. You have to inform them of it and give them another physician, refer them to take over care. Okay, otherwise it's considered abandonment, and they may be liable for that. Okay, so I have a couple questions for you guys here. So we talked about the ethical principles here. Good. So you guys said autonomy, excellent, and beneficence. So doing right by the patient, certainly. Good. And then we talk a little bit about non-malfeasance also, which is that kind of classic do no harm thing that you guys think about when you say the Hippocratic Oath, when you're a medical student and you have your fresh white coat, and you take that oath. So my question for you guys now is, what is the best course of action for both the patient and the physician in this instance? So and then the second kind of question that goes along with it. So if you want to unmute yourself and answer either question. And then the second one is, how should physicians act when their morals, values, and belief differ from their patients? What do you guys think about those two questions?
I think that the physician could recommend getting a second opinion.
Mm-hmm.
And so if their own beliefs don't align with their patients, they can say, hey, I think that this physician could be a better fit for you.
Good. Perfect. Yeah, I agree with you. And oftentimes physicians work in groups, so you can recommend that they see one of your partners and get a second opinion. I think that is also, a reasonable thing, but a very professional thing to do as well. And you may not believe in something, or an alternative form of medicine, and that's okay. You form certain preferences and opinions throughout your training and stuff, and you may have found that you formed that impression because it didn't work for your patient in the past, which is all kind of based on the culmination of your experiences. So you may have kind of grounds in that opinion, which may or may not have been known to the patient, but at the same time, what we're here to do is benefit the patient. So good, I agree with that. Anybody else have any other thoughts?
For the second question, I believe the physician should remain neutral, and they should not try to inflict their beliefs on the patient, and just try to do what's the best for them, so benefit them. And yeah, that's it.
Good. So for someone of whom has back pain, the patient wants to go to acupuncture, the surgeon or the physician wants them to go to surgery, what's a middle ground for this patient? Do you think something that's reasonable, that we can say, okay, you don't want to do surgery, which I understand, cumbersome, especially if the patient is, older, or has, comorbid conditions, whatever the case is. I don't necessarily agree with acupuncture, the physician may say, but what's a middle ground, do you guys think? So Matthew says physiotherapy. That's a good idea. I had one other thing in mind, kind of along the same lines.
Would seeing a chiropractor count?
It could. If somebody has pretty acute back pain, chiropractor could arguably exacerbate it depending on the therapy. But it could be an option. Never say never. Acupuncture, and if that doesn't work, then do surgery. Yeah, we can make a plan. But we, like the last patient, we want to explain the risks and benefits of this. We don't want what's going on to cause cauda equina syndrome, which is a medical emergency. Medication alternative, yeah, pain management, and therapy alternative. Good, Adam, I agree. My thought was, maybe we can recommend physical therapy. I don't, the physician may say, I may not necessarily know the risks and benefits associated with acupuncture because there's not a lot of big trials in it. But if that's something that you want to try, you certainly can. And, if that doesn't work and if physical therapy is not helpful in alleviating pain, maybe we can revisit this in 6 months, 6 weeks, and see if surgery is a good option at that point. So I think you guys are on the right track with all of that. And this physician, saying that these things are placebos at best, maybe kind of, on one side or the other, kind of asserting their opinion. But we found that placebos do a lot in a lot of regards. So even if it's just that power of, mental fortitude to overcome the pain and stuff associated with it. So lots of things to consider here. Anybody else have any other thoughts or questions about this? All right, so let's go on to case 3. As a disclaimer, it's pretty long. If somebody reads the first part, I'll read the second part. How about that? Oh, and then somebody said do PT, then take a follow-up X-ray or whatever technique, yeah, or CT, whatever, MRI, and then go from there. Yeah, I agree with you. But making that plan and getting the patient on board, I think is a great step for this. So good. I think you guys are on the right track here. Good. All right. So let's have somebody read here.
I'll read it. Sorry ahead of time if you hear my baby.
Oh, yay.
So, I don't want to butcher this name. Farhad Tabrizi, a 69-year-old immigrant from Iran, is brought to the emergency room at St. Vincent's Medical Center, a private urban hospital, after coughing up blood. He presents with severe coughing, fatigue, chest pain, shortness of breath, and headaches. After stabilizing Mr. Tabrizi, the emergency room team admits him to the hospital, where he is given, over the course of a few days, a thorough workup, including chest x-rays, CT scans, I have no idea how to say that, and a PET scan. At the start of the visit, the nurses attempt to gather a detailed health history, but this proves difficult since Mr. Tabrizi speaks almost no English. He does speak fluent Farsi, but there are no Farsi-speaking medical personnel readily available. However, Mr. Tabrizi is accompanied on and off by his adult son, who is reasonably fluent in both English and Farsi. He is also accompanied intermittently by his wife, who speaks only Farsi. The wife makes it a point of regularly offering prayers for her husband's health. The nurses attempt to gather a health history whenever the son is present, which is not always easy since his visits are unpredictable. Even when his son is present to help translate, Mr. Tabrizi seems extremely uncomfortable offering up any detailed information about his own or his family's health history, causing high levels of frustration among the medical staff. Additionally, Mr. Tabrizi appears extremely reluctant to eat whatever food is offered to him in the hospital. This is most pronounced when he is alone, if neither his son nor his wife is present at mealtime. On the second day of his stay, his son explains to the flustered nurses that Mr. Tabrizi is fearful that the hospital food may contain hidden pork byproducts. Since he is a devout Muslim, he feels it is safest to refuse the food altogether unless he is absolutely certain. Although the son has attempted to persuade Mr. Tabrizi that he, as a sick person, must eat, Mr. Tabrizi apparently is determined to eat as little as possible. The chief nurse curtly replies that while religious belief is important, Mr. Tabrizi needs to keep his strength up if he hopes ever to go home. Thus, he will need to nourish himself by eating more. She says that she will see what we can do about ensuring that there is no pork used in the hospital's food preparation. The son thanks her for her help. From then on, he and his mother attempt to bring outside food to Mr. Tabrizi.
All right. So I will take this one unless anyone wants to really dying to read. Thank you for reading. You did very well. Probably better than I read. So after almost 3 days in the hospital, the results of the various scans are in. And the attending physician, Dr. Look, sits down with Mr. Tabrizi to discuss his situation. His son and wife are also present. Dr. Look offers a handshake to Mr. Tabrizi's son. He inquires explicitly about the extent of his English skills and asks if the son would be willing to translate what he is about to say to Mr. Tabrizi. He agrees while Mr. Tabrizi and his wife sit by. The doctor then gazes directly into Mr. Tabrizi's eyes and tells him that he has an extensive small cell lung cancer. After a moment of stunned silence, the son turns to his father and tells him that the doctor believes that he is very sick with some growths in his body. Dr. Look goes on to say that Mr. Tabrizi most likely does not have long to live. The doctor holds up 2 fingers, at which point the patient grows increasingly alarmed and agitated, describing that there are basically 2 possible treatments for this cancer: chemotherapy and radiation. Dr. Look strongly prefers beginning with the first, chemotherapy. In spite of Dr. Tabrizi's alarm and confused expression, the doctor presses on that given the apparently advanced stage of the disease, even chemotherapy would be unlikely to provide a complete cure, but it could provide some relief and lengthen the remainder of his life. The son, again silent for several moments, then turns to his father and also holds up 2 fingers. He tells him that the doctor says he must do 2 things to care for himself: eat well and get more rest. He also relays that his father could take some strong medicines, which would most likely help to get him better. Mr. Tabrizi looks extremely uncomfortable, but says nothing. A few more moments, and Mr. Tabrizi, somewhat confused, asks via his son what the strong medicines would consist of. The doctor replies by describing in some detail what the course of the chemotherapy would look like, how often it would be administered, and that the treatments would last for several weeks. He also describes that it may produce severe side effects such as nausea, vomiting, increased fatigue, and elevated risk of infection. In spite of his hesitations, the son attempts to translate the bare outlines of this information, leaving out the term chemotherapy, at which point Mr. Tabrizi declares flat out that he doesn't want any such cumbersome treatments. They would compromise his relationship with his family and friends and place too heavy of a burden on his wife. Further, he doesn't really know what might be in such a strong medication that could help him to get better. Instead, he will simply do the 2 things the doctor had recommended and improve his diet and get more rest. Now the question is, what should or could the doctor and hospital have done differently in order to handle this case in a more helpful manner? So what are your guys' thoughts about this? Could have gotten a Farsi translator, good. Anybody else with any ideas?
Could the physician have drawn pictures out so it could have been like a visual representative?
Sure, yeah, I agree. Tried to Google Translate, worst case, find a translator, I agree. A lot of hospitals have that in place, the kind of iPads that talk to them and kind of translate. What's something that the physician could have done in order to gauge this family's understanding of what this physician's saying?
Definitely could have asked like more questions, checking up what they understood.
Exactly. So a lot of people prefer kind of the teach back method. So tell me what you understand. A lot of people start out with that too. You know, tell me what you understand about what's going on. That way you can kind of gauge your conversation and kind of speak up or you know, at their level, depending on what they know. And yes, asking, you know, is there any questions, giving them the opportunity for questions and kind of gauging their understanding of what you said. Because the reality of it is, in this instance, and really any instance, if somebody hears cancer, they don't hear anything after that. So a lot of candid discussions and very clear conversation lines have to be had in terms of understanding, you know, what is going on. So what's the big issue here with this patient and what kind of went on? There's a very long case, obviously, but what's the issue at hand that we're talking about here?
The son isn't being entirely honest with his father, which is leading to he's not getting the correct information about what's wrong with him.
Sure. So do you guys think that it was a matter of the son withholding information, or a matter of kind of an inability to translate all of the information entirely?
I think it was both. It's sort of like a communication mistake in like both parties.
Okay, so let me pose another similar situation, and you'll see this, I guarantee, between, you know, probably at least the time you graduate residency, or if not, you know, when you're an attending physician. But suppose you know, patient X was diagnosed with colon cancer. The patient just came out of the colonoscopy, and they you know, or the path results came back, and you know, after the colonoscopy, the family said, you know, if this, because the patient lost a lot of weight, you know, had blood in the stool, there's a history of colon cancer, and the spouse and the family says, doctor, if this is colon cancer or anything that's bad, can you promise that you won't tell the patient, just tell them that they need to get more rest and you know, focus on their diet? Is that ethical for the physician to do in that circumstance? So basically, the difference in the case that I just gave you is that there is no language barrier in this instance. So is it ethical for the physician to say, okay, yeah, I won't tell the patient what their diagnosis is? Yeah, it's not ethical. You guys are right. So, and we're going to talk about situations about withholding information and stuff like that. But, you know, it's not ethical because the patient has the right to know their diagnosis. Times where, you know, that may be a different story is pediatrics. If the patient has the intent to harm either themselves or other people, and obviously their safety is at risk. So there seems to be a little bit of a dialogue in the chat. It seems like you guys are kind of split in terms of whether, you know, whether the son was withholding information or was kind of that communication barrier. But either way, I think it brings up good kind of things that we're talking about here. So my questions that I kind of posed, and we kind of talked about this, the issues at hand is kind of that conversation, the language barrier, perhaps withholding information. But my next question for you guys is, what is cultural competence? So I know that that's a vague question, but tell me in your best words what cultural competence is.
Understanding and respecting other cultures.
I agree. And that's absolutely essential, obviously, in medicine for a multitude of reasons. And so Emily has her hand up. Go ahead.
Oh yeah, I just wanted to add on to that. A part of cultural competency is also understanding that you'll never really fully understand someone's
Good.
culture, and that like it's a learning process and you'll never fully understand like other people's backgrounds, but you can do your best to learn more about it and see what you can do to help them understand how their culture plays into like the medicine that you're working with and things like that.
Absolutely. Good. And that was exactly what I was just going to say. So you took the words right out of my mouth. And I think that that's absolutely true. And, you know, I think there's a lot of self-awareness, a lot of open-mindedness to have that thought process in your head to say, you know, look, I'll never know everything about any culture that you know, perhaps isn't mine, but I can make a conscious effort to constantly evolve my knowledge in order to not allow that you know, lack of knowledge or someone's culture or race or religion or belief or background to hinder the way that I treat them. So it's so incredibly important. So good. Anybody else have anything to say about cultural competence or its importance in medicine? Okay, good. So let's see. So I have a couple of things in terms of the summary, and then I'll get you guys going here in a few minutes. So the things that we talked about today are primarily a kind of a culmination of these 4 principles here, and these are the ethical principles that we see and talk about most often. So beneficence, which means doing right by the patient. Non-malfeasance, which means do no harm. Autonomy is that ability of the patient make that decision, you know, whether we agree with it or not, you know, on their own behalf. And justice, which is also that idea of doing what's right. Okay. And there are a few famous cases, one of which is the duty to warn case. So this is a kind of famous case that created this idea of duty to warn. It was a psychiatrist of whom had a patient that that said, you know, I'm going to, had homicidal ideation, said I'm going to kill my, you know, my girlfriend, my significant other. And that at that time, there was no kind of safeguards or standards in place to sort of avoid that. That patient that voiced those homicidal ideations actually went and killed that that girlfriend. And so that case, as a result, resulted in this idea of duty to warn. So if a patient comes to me and says, I am going to kill, you know, this person, I have the obligation as a result to notify the authorities, to notify that person, to protect them as a result. So that's what duty to warn is, okay? And then, you know, you guys have probably taken 1,001 HIPAA courses, and you guys could probably teach me something about HIPAA. But when we talk about HIPAA, that's Health Information Privacy, Affordability and Accountability, or Accountability Act. I probably said it wrong. I know I did. Maybe I should take another course. The Health Information Privacy and Accountability Act. There it is. So in exceptions, when we say, okay, when, and it kind of goes along with duty to warn, when, or what are the exceptions to HIPAA? If there's a violent crime, if we have a suicidal patient, child or elder abuse, obviously we need to inform the correct authorities. Infectious diseases, we have the right to inform both partners and the health department. Gunshot or knife wounds, that kind of goes along with the violent crimes, and then danger to others. So that's like homicidal ideation. So that's a little bit about duty to warn and HIPAA. And then other things, we obviously talked a little bit about cultural competence, conflict of interest. We inadvertently talked about that. Malpractice, when we talk about malpractice, is a physician, you know, at, you know, risk of this idea of malpractice. And what we think about is the 4 Ds. So did the patient have it, or did the physician have a duty? A dereliction of duty, which means sort of this abandonment of their duty. Was there damage done? And was there a direct cause, or was their actions the direct cause of damage? That's the 4 Ds when we talk about malpractice. Is somebody sort of liable in terms of malpractice? Care for minors, that's such a long topic. The biggest one that people like to ask is this idea of, a 14-year-old comes in and asks for birth control pills, would you give it to them? The answer is yes, because they can. Minors don't need a parental consent for reproductive health. So if the patient got pregnant, you would likely really encourage that the patient go to their family or their support system to have that support in place. But you don't have to get consent from the parents for reproductive health. So that's often a topic in ethics as well. End of life care, we talked about advanced directives, we talked about futile treatment, and euthanasia and physician assisted suicide. That's a big thing. I think it's only legal euthanasia and physician assisted suicide, if I'm not mistaken, in 2 states, but I could be wrong, and it could have changed since I last saw those the statistics. And the idea of withdrawal of care, so that goes along with the advanced directives. It goes along with palliation, so palliative care and hospice care. So I'm 90% certain that's my last slide. Oh, there's a few more cases here. So we talked about duty to warn. Respondent superior, that is this idea of the hospital kind of being at risk for its employees. So this case was a physician of whom the patient had like a fibroid tumor, didn't want it removed, and then consented under anesthesia, which is like, is unethical. The case kind of established that the hospital can be liable for its employees, so that physician. Liberty to choose, the big case we talk about is Roe v. Wade, which I'm sure you guys are familiar with. And then the last case that I have listed here, and there's tons of cases that we talk about, is this Morby Regents of the University of California, and that's the right to one's own cells, whether that's for vaccinations, for experimental purposes, or other regards. Okay, so that's a few things in cases wise that sort of formed the precedents with which we kind of approach medical ethics. But I think that's my last slide. Okay, let me send the poll to you guys here and launch it again, and let's see what you guys know and see the kind of delta between the two. All right, and while you guys are filling that out, I will stick around for a few minutes, answer any questions you guys have about ethics, about applying to medical school, about anything, my favorite books, I'll talk about that, what I like to do, I'll also talk about that. Whatever you guys want to talk about, I'll stick around for a few minutes afterwards and answer any questions. But it looks like the vast majority of you guys, I'll end this poll here and share these results, said you know some or you know a lot, which I'm very humbled by. Nobody said they know nothing, which is great. Always a good sign that I've taught you at least something. So excellent. So, obviously this wasn't a comprehensive medical ethics lecture. We can always do a second part of medical ethics if you guys are interested in that and enjoyed tonight's session. You can give me like a yes or no in the chat if you're still around. But otherwise, I will stick around for a few minutes, answer any questions you guys have. Otherwise, take care and have a good evening. So we have one question. So in the first case, does the physician just not consider, sorry, I keep losing, not consider if they're in a state where assisted suicide is illegal? So if he wants to die, does the physician just not consider? Yeah, so, right. So, exactly. So in the vast majority of cases, or states, it's not legal. So that's often not a consideration. It is not something that's usually taught in training or education. So we're going to want to consider, can this patient benefit from dialysis? And if yes, and it's not a futile treatment, then, let's treat this patient and see if it's beneficial. And if they are in a state where it's, legal, then, maybe we want to have sort of candid discussions about the patient's prognosis and see, if the risks outweigh the benefits in terms of dialyzing the patient. Okay. I hope that answers your question. Okay, so let's see. Another ethics, great. Yes, you guys are very welcome. With step 1 going pass fail, is it still viable to apply to international med schools? Thanks for all your help. I don't know what you mean by viable. I think it kind of in terms of international med schools, it kind of levels everybody's playing field across the board and places more emphasis on clinical skills and your ability to learn in that regard. So it takes the pressure off of getting scores and grades and more of your merit in terms of how you do in your rotation. So your evaluations, your letters of recommendation, and people kind of vouching on you in terms of that. So, exams kind of are check boxes that you've done those things, so you've met those requirements. And now it's kind of more of a focus on your knowledge base, your letters of recommendation, and stuff like that. So I would say, whether it's, allopathic, osteopathic, international, Caribbean schools, it kind of, makes everybody, competitive. A pass is pass. I don't know if it's going to place more emphasis on, step 2 in terms of that actually having a number. I'm not sure how that's going to change because all of my exams are scored. So it was a little bit different. So it's easy to kind of speculate what that is, but the theory behind it is it kind of places everybody at the same on even ground and place more kind of emphasis on really those clinical skills. Okay. Yeah, so you can retake the quiz. You can take it like 100 times if you wanted to. I don't think it'll take you 100 times to get a 80 or 100% or whatever is required. But yes, you can take it as many times as you need. So it's not just one attempt. So don't get stressed out when you're like, I have to choose all the right answers. You should definitely put in an effort. But if you get one wrong, that's okay. You could retake it. How much free time do you have in medical school? That definitely depends on the year. It felt like my first 2 years, I really had to make time for, myself and my family and the things that I like to do. And then, I got to my 3rd year and I had like more free time than I knew what to do with. And I was like, holy crap, I have no hobbies. And so I had to like get hobbies and, learn how to be a person again. So it definitely depends, but you won't have no time to do anything but medical school. So don't be worried about that. You can certainly make time for the things that you enjoy doing, and because those are the key things that kind of keep you sane when you're in school. Let's see. Sorry if this produces a new question. If the treatment seems to be futile and it's in a state where it's illegal, what obligation does the physician have at that stage? Keep trying? No. So in that instance, we might, if the treatment is futile, that's probably where we're going to get hospice care and palliative care involved. So when we talk about palliative care, that's usually, palliation for end-of-life care. Hospice is if there's less than 6 months. So if that's the case for this patient, we might get them involved to have that patient, be comfortable in end-of-life care. And if they, have decision-making capacity to refuse dialysis, we might have candid discussions about, what is going to happen, what we can do to make this patient comfortable. And if the patient refuses, obviously, and they're able to make decisions, we have informed consent and everything's kind of, obviously documented. We wouldn't keep kind of pushing until they, have dialysis. They have the decision to make decisions on their behalf if they are in fact, have the capacity. So, we might kind of lean more towards, palliation and hospice at that point. Any other questions out there? You can ask anything you want. It doesn't have to be ethics. Good questions, by the way, with ethics. I think you guys did a good job kind of talking about all these principles and considering lots of things.